IUDs, or intrauterine devices, are a hot topic of discussion right now. There's a lot that can be learned about them, and there's a lot that's out there that comes from sources that might not be entirely reliable. So I'm Dr. Monica, I'm a board-certified OBGYN and mom of 3, and in this video I want to provide you with evidence-based information so that you can gain education about IUDs. What are they? What are they used for? How do they work? Risks and benefits, and some information that can help you decide if maybe it's something you might want to use for either contraception or treatment of heavy bleeding. And of course, we'll get into some myths and go ahead and debunk those at the end as well. So let's go ahead and get into it. So an IUD, intrauterine device, is a device that's placed in the uterus to provide contraception. That's what it was initially made for. And as we've developed different types of IUDs, we're finding that our ones with hormones are also fantastic treatments for heavy menstrual bleeding, for painful periods, and for other issues that women have just as they have periods that they maybe don't like to deal with. So let's get into the different types first. So on a basic level, there are 5 different types of IUDs. There is one copper IUD called the Paragard. This is the Paragard IUD. As you can see, there's copper wrapped around the body of the IUD, as well as up here on the arms of the IUD. So this works as a contraceptive device to prevent pregnancy by inhibiting the way that sperm can move through the uterus so that they can't get up to meet with an egg and make a pregnancy. The copper IUD, one of the best advantages of it is that almost anybody can use it because it doesn't have any type of systemic effect. It doesn't have any hormone in it. So people who otherwise maybe can't have certain types of treatments can have a copper IUD. That's one of the advantages. Now, this comes with a little bit of a caveat in that one of the side effects of it is that it can cause increased menstrual bleeding and some cramping with your periods. Now, that's not everybody who experiences that because some people have very light periods to start with, so adding a little bit of that irritation from the copper doesn't make a ton of difference. Or people just want reliable contraception and they don't mind if their periods get a little bit heavier, or people are just okay using different types of NSAIDs such as Motrin, Aleve, ibuprofen, that type of thing to treat cramping and just want reliable birth control. Now, with that being said, about 9.7 out of 100 users will discontinue the copper IUD because of the cramping and bleeding side effects. In terms of contraception, it works great. There's only a 0.2% chance of pregnancy within 1 year of use of the copper IUD. Now, all of our other IUDs are hormonal IUDs, so they all secrete the progesterone hormone levonorgestrel. It should be noted that neither the progesterone IUDs nor the copper IUDs work by aborting a previously existing pregnancy unless they are used for emergency contraception. So when they're used naturally, already in place, it just prevents a pregnancy from happening. It doesn't let it happen and then stop it once it's already in place. So these hormonal IUDs work to prevent pregnancy by thickening the cervical mucus and thinning out the lining of the uterus. This makes the cervix so that it's impenetrable by sperm, and then the lining of the uterus is not a good environment for an embryo to implant because it's not been able to thicken up and make that type of thicker tissue for an embryo to implant in. There are 4 of them and they have different amounts of hormone in them and secrete different amounts of hormone. These 4 IUDs are the Mirena, Liletta, Kyleena, and Skyla. Mirena and Liletta are both 8-year IUDs, so they can be used for contraception for 8 years. They have 52 milligrams of levonorgestrel in them, and they secrete them at similar amounts in that the Mirena IUD secretes about 20 micrograms of the hormone a day, and the Liletta IUD secretes about 18.6 micrograms of the hormone a day. The Kyleena is very slightly smaller than the other IUDs. This is the approximate size of the Mirena and Liletta IUDs. This is the body where the hormone is. These are the arms, which does not have any hormone in them. Now, the Kyleena IUD is minimally smaller than the Liletta and Mirena IUDs. Now, the Kyleena has the same hormone, the levonorgestrel. It contains 19.5 milligrams of the hormone, and it secretes it at 17.5 micrograms a day. This one is good for 5 years, at which time it needs to be removed and a new one placed. The Skyla is the final IUD. This is the smallest one. It is good for 3 years. It has 13.5 milligrams of the levonorgestrel, and it secretes that at 14 micrograms a day. So when we talk about side effects of the IUDs, there are different side effect profiles for the hormonal IUDs and the copper IUD of Paragard. We talked a little bit about the ones for the Paragard already, and the main side effect is increased bleeding and cramping with the menstrual cycles. Since there's no hormonal effect, you will still have regular cycle intervals if you have normal menses already. It won't change the interval of your period, and the main side effect that people encounter is the cramping and the bleeding. Now, when it comes to the hormonal IUDs, the main side effect that is seen is irregular bleeding, and sometimes the irregularity of this bleeding is actually the desired effect. The Mirena and Liletta are FDA approved for treatment of heavy menstrual bleeding. So we will be using these IUDs sometimes not in the setting of contraception, but in the attempt to treat heavy menstrual bleeding. Kyleena also shows some improvements on heavy menstrual bleeding and is sometimes used in that effect as well. So the main side effects with the progesterone IUDs is the irregular bleeding. As time goes by after their place, you'll see a change in the bleeding profile. It's very common the first 3 months to see a lot of irregular bleeding, sometimes a little bit on the heavier side, a lot of spotting, and this is just because that lining of the uterus is slowly thinning down as the progesterone is present over time. So I tell patients for the first 3 to 6 months, we want to really have some patience with what we're seeing with the bleeding. Of course, if it becomes where you can't deal with it, we can always address it sooner, but generally our plan that's in place and our expectation is that we're going to give this 6 months to settle in and see what we're looking at. A lot of the times once we get to the 6 months, we're going to see that spotting and irregular bleeding has lightened and has become less frequent, so that by the time we get to where we are kind of in that bleeding profile we usually see light spotting, a little bit of light irregular bleeding, less likely to have heavy bleeding. Now the actual stats on the bleeding is that after a year of use, studies show anywhere from 20 to 50% of users will have no periods, or what is called amenorrhea. Most of the newer studies are indicating about 20%, but some studies have indicated up to 50% of amenorrhea after 1 year of use with one of the hormonal IUDs. Other less common side effects that are possible from the hormonal IUD, because there is a little bit of systemic absorption through the bloodstream, are headaches, nausea, and mood changes. Mood changes are more likely in people who are already predisposed to having some type of those changes in the past, but these are all low risk for having these things happen. There has been no demonstrated weight gain when using a hormonal IUD. Weight gain was studied comparing the hormonal IUD to the copper IUD, and there was some weight gain noted, but it was the same. So there's not an impact of the hormone making you gain a ton of weight, and there's not a significant amount of weight gain that's been consistently demonstrated in studies. Some risks of IUD insertion are uterine perforation, which is not common. This happens statistically in 1.1 to 1.4 of every 1,000 insertions. So this is not something that happens often, but it is a risk. Expulsion is another risk of having an IUD placed, and this is when the IUD is dropped back out of the uterus and out of the cervix. So this is something that happens anywhere from 5 to 22% of insertions, indicated by a study that looked at IUDs that were placed in patients who had never had a baby. This is also more common in certain situations, such as if they're placed immediately after delivering a baby. There's a higher risk of expulsion at that time. The good thing about expulsion, although it definitely sucks because you just went through an insertion and then it's come back out, is it's not actually harmful to you. Whereas a perforation, of course, can cause some issues with the IUD being loose inside the abdomen. Fortunately, that is much less likely to happen, as noted by the stats I gave you before. And then the biggest risk of IUD insertion, which is certainly experienced by different people to different degrees, is just pain on insertion, where you're placing an item up in your uterus. So this can be quite painful. And it's an area that's difficult to look at because pain is always difficult to study and everybody is so incredibly different. So any OBGYN, I'm sure, will tell you that they've placed IUDs in people who didn't seem to have it be any different than a regular pelvic exam, and then we placed it in people who just straight up couldn't tolerate it because it was too painful. It's one of those things that has a big spectrum. I have more information about that on my video about pain management options for IUD insertion. Now, there are a few contraindications to placing an IUD. Only a few though, which is great because that means that a lot of people are able to use them. But in general, an IUD is contraindicated for either the copper or the hormonal IUD in the instance of a uterine malformation. So some people have a uterus that is not formed the way it should be. So instead of having, if this is your uterus, instead of having this open cavity in the middle, some people will have a septum down the center or have only one side of their uterus that's really formed, or have large fibroids that are encroaching in this cavity of the uterus. In that event, you shouldn't place an IUD because you don't know that it's going to be able to sit safely in that cavity. Other contraindications include an active STI, so an active sexually transmitted infection, cervical or uterine cancer, although there's a caveat to the uterine cancer portion, but cervical cancer is a contraindication of placing an IUD. And then there are some relative contraindications. That means situations where you might want to closely evaluate your risks and benefits and see if an IUD is truly what you would want to have placed. Now, I mentioned the caveat about the uterine cancer because the Mirena IUD is actually approved for treatment of early stage endometrial cancers and hyperplasias, which is an overgrowth and abnormal growth of the cells in the endometrium. These are sometimes used in women who want to preserve their childbearing in situations of endometrial cancer. So that, however, is kind of a different situation because the IUD is being used as a cancer treatment. The contraindication that comes with that is more on the lines of if it's being used just for contraception or for treatment of bleeding. So all the education about IUDs is to give you knowledge and information and empowerment about this device that may be an awesome option for you or might not. But making that decision can be very difficult, especially in this day and age where there's all this influence from social media and from outside sources that may not necessarily be evidence-based. So I want to take you through some numbers. Numbers coming up from peer-reviewed research, I think, are a little bit more of a tangible way to look at the risks and the benefits and think about everything, of course, on an individual basis if something looks like it might work for you. So let's kind of run down the risks and the chance of that happening, and then look at the benefits and kind of compare the two. So the risks we talked about, the perforation and expulsion, and the pain on insertion. Pain on insertion is its own kind of category. We talked about the perforation risk being 1.1 to 1.4 out of 1,000. It's very low risk of that happening. And then the expulsion rate being varied, but anywhere from 5% to 22% expulsion rate. And then we talked about how if that happens, although it sucks, it doesn't really lead to any actual harm. It's just, unfortunately, the device is not in place. Then we talked about some of the side effects that can sometimes be a hindrance to continuing the device. So with the copper IUD, we have that risk of cramping and heavier bleeding with the cycles. And then we talked about the irregular bleeding and some of those other less likely systemic side effects that come with the progesterone-containing IUDs. I think the best numbers to look at when you're thinking about these things is the rate of discontinuation for certain reasons, and then how many people still have an IUD device in after 1 and 3 years. There were some research studies that gave some data on this, and I think that helps to prompt an idea of all users, what's the chances of this working out? So we mentioned before that the copper IUD, about 9.7 out of 100, so 9.7%, ended up discontinuing that copper IUD device specifically because of the cramping and the bleeding that came on with their periods. Now, the progesterone IUDs had a much lower percentage of this, 1.3 out of 100, so 1.3% of users discontinued it due to heavy bleeding and cramping with their periods. So it's a very low amount of people who found the side effect changes with their bleeding to be an issue enough that they discontinued it. Now, similarly looked at was, and the copper IUD, this didn't technically apply to because they never have no bleeding or spotting, they just have normal or the same periods or heavier. But another study actually looked at the amount of users who discontinued a hormone-containing IUD because of the irregular spotting or not having periods if that was bothersome to them. And that was about 4.3 out of 100 users, so 4.3% discontinued use of the device because of that side effect. For the hormone-containing IUD, research has indicated that 87% of users still have the IUD in place after 1 year, and about 69% still have it in place after 3 years. Now, this didn't look at reasons for removal like the prior statistics I told you that were specifically for those reasons. People may have had them removed because their partner got a vasectomy and they didn't need it, or they wanted it out to have a baby. For whatever reason, that was the continuation rate. 84% of the copper IUD users were still using it after 1 year, and similar to the hormone-containing, 69% were still using it after 3 years. Now, if you compare that to birth control pills or depot shots or other non-long-acting devices, you'll see a significant difference. So for all LARC, which is long-acting reversible contraception, non-LARC users, so birth control pill, shot, patch, that type of thing, only 55% were still using their form of contraception after 1 year, and only 31% were using that type of contraception after 3 years. So again, that's a very broad number, and there's a lot of different reasons that someone may have chosen to remove it. It's not necessarily because they couldn't tolerate it or didn't like it, but that's a pretty significant comparison. And I bring these numbers up to you to compare the reason they removed and how many stayed in place. Now, another risk was the expulsion rate. We mentioned that was 5 to 22%. I want to compare that to the rate of successful insertion in a nulliparous, so that means someone who's never been pregnant, patient, which is 95%. So 95% of the time, the insertion is successful, which is a really nice statistic to see, to know that there's a 95% chance if I go get this IUD placed, it's going to be successful. And when we talk about comparing these stats, again, I think a significant stat to compare is the 90% reduction in bleeding, the 20 to 50% rate of amenorrhea, compared to those lower rates of removal. Some other benefits to the IUDs that is something to consider when you do potentially want fertility in the future is that even though they work excellent for being contraceptive and prevent pregnancy, they're all reversible. So once they reach the end of their time when they expire, you can switch them out for a new one if you still aren't ready for a baby, but they can all be removed earlier. So although the Liletta and the Mirena are good for 8 years for contraception, the Kyleena for 5, the Skyla for 3, and the copper IUD for 12, all can be removed sooner if you want to have a baby and want to go ahead and try to conceive. Your return of fertility is immediate as soon as they're removed, so you can get right into trying to have a baby as soon as they come out. There are no long-term effects or decreases in fertility from using these devices. In actuality, there is a possible reduction in endometrial cancer from using the hormonal IUDs. So these are some other nice benefits of these options for you as well. It's a little hard not to get caught up in the benefits of these things because from the standpoint of a clinician who sees and treats a lot of patients, we want to give them as much good as we can from the different contraceptive options. An important detail when you're considering using an IUD for contraception is how well does it work? And the answer is very well. So a copper IUD has a 0.8% chance of pregnancy in 1 year of use, and a hormone-containing IUD has a 0.2% chance of pregnancy in 1 year of use. If you compare that to a birth control pill, you'll see that there's a difference based on what's called perfect use and normal use. So perfect use of a birth control pill has a 0.3% pregnancy risk for 1 year, but typical use, meaning how the average woman actually uses it, taking pills a little late, missing a pill here or there, is actually a 9% risk of pregnancy over 1 year. So you can see that the comparison between those two particular methods shows that IUDs are very effective for birth control. Additionally, a copper IUD, which can be used for up to 10 years, shows similar rates of pregnancy as a tubal ligation. And again, it's reversible, so you get that consistent, reliable birth control, but it can be reversed if you want. And for my favorite part of the videos is going through some of those myths and things that are out there in the world of the internet that are not accurate, but people hear a lot and sound concerning to them. So the first one I want to address is the myth that an IUD will increase your risk of an ectopic pregnancy. So this is not true. Here's where this comes from. The chance of pregnancy with an IUD in place is very, very low. But if there were to be a pregnancy, it is more likely to be an ectopic than in the uterus because the IUD is in there. You know, it's less likely that something can get in there and implant in the uterus. This does not increase the risk of ectopic pregnancy. In fact, it's actually a lower chance of ectopic pregnancy than someone who doesn't have an IUD in place. That line about it being more likely to be ectopic than in the uterus is what morphed into that misconception, but there's actually reduced risk of ectopic compared to someone who's not using an IUD. Another thing I hear is that the copper IUD works by aborting a pregnancy that has already formed, and this is not true. Now again, IUDs can be used as emergency contraception, meaning no form of contraception was on board, unprotected intercourse occurred, and the IUD was placed as an emergency contraception. That's a different situation. When the IUD is in place and being used for contraception, it does not allow a pregnancy to start and then abort it. It works in the ways that we talked about, which is the thickening the cervical mucus, thinning the lining, and for the copper IUD, preventing the sperm from being able to move up into the fallopian tubes and meet the egg. So it does not provide an abortion effect. A very common myth I hear is that you cannot use an IUD if you've not been pregnant or had any babies yet, and this is not true. There's actually been more research recently about using IUDs in adolescents and nulliparous women, which means they've never been pregnant, and they are fine to use. Now, we do see some more times where people have more of the issues with pain on insertion, but it is perfectly safe to use in someone who's not had a pregnancy yet, and depending on the particular person, it might be a great option for contraception. Hear this one a lot, even amongst the medical community, the idea that the IUD increases the chance of pelvic inflammatory disease or causes STDs, causes STIs, that whole idea with the infection. So here's the fact of it. It does not increase your risk for pelvic inflammatory disease. It does not increase your risk for STIs. Some people who begin using the IUD stop using condoms. Condoms prevent the STIs. The IUD does not. So it's important to continue using condoms to prevent STIs. The IUD itself does not cause there to be an STI. Now, in terms of the pelvic inflammatory disease, there was this idea that because the string hangs out of the cervix, that bugs can crawl up into the pelvis. And that's not a silly idea. Foreign bodies within the human body sometimes are causes for infection, but research has not indicated any increase in pelvic inflammatory disease in IUD users. The one instance in which it does indicate there's a risk of increased infection is if there's an active chlamydia gonorrhea infection at the time the IUD is inserted. So that is where the actual process is bringing some of that bacteria up into the uterus. But it just being there and then a new infection coming in does not seem, based on research, to cause an increase in pelvic inflammatory disease. And interestingly, if the IUD was placed and let's say someone came in for a placement, IUD was placed and a screening test was done to check for chlamydia gonorrhea and it was found to be positive, you actually don't have to remove the IUD. You can just go ahead and treat it and the IUD can stay in place, assuming there's no severe infection in place. There was a myth that the copper IUD causes the fallopian tubes to be scarred and obstructed. This idea coming from how the copper can be a bit irritating and prompted this myth that it would block the fallopian tubes and cause infertility. And this is not true. There has been research done on that on ladies who have tubal infertility, which means that their tubes have been obstructed and are blocked. And that was found to be correlated with chlamydia, not with the copper IUD. Now, another topic which doesn't really belong in the myth category, may belong more in the general information category, is the idea of breast cancer and the hormonal IUDs. And right now it's a little bit mixed. So some research is indicating that there may be a possibility that a hormone-containing IUD could be a bit of a risk factor for someone who has a predisposition for a progesterone-sensitive breast cancer. It's really mixed right now, so I'm gonna just say the jury's out on that one. I do see some colleagues who work in breast care who discourage from using hormonal IUDs in patients who have personal history of progesterone-sensitive breast cancer. I think still more research to come on that to give a good final answer for that one. So a lot of OBGYNs really like this device because it can be used in so many different people. There are relatively few contraindications. There can be great effects on the bleeding profile, and it's used in people who otherwise have medical problems that might contraindicate other types of birth control. It's super reliable for contraception, and it's low maintenance for the patients, meaning we place it for you in the office and then you kind of set it and forget it. You don't have to be taking pills every day or remembering to take shots or any of the things that come with other forms of birth control pills. Now, something that's important to remember, you may see things out there on the internet of people talking about their experiences, and those are valid experiences, and there's a whole array of outcomes and experiences people can have with these devices. I would encourage you to try to consider research studies and research-based information, because any one person can have any one experience. When I talk with my patients about IUDs, I really tend to not give them my input because that's just what happened to me. And that doesn't mean that that's going to happen to them or they'll have a similar result or outcome. Now, if I'm specifically asked, hey, have you used an IUD? What was your experience? Yes, I will tell them that I used one. I had a great response. I had no menstrual bleeding. I had all these great things. But I'll mention the caveat that this is the percentage chance that that will happen for you. Things might be totally different from you. That's just one person's experience. Just like it wouldn't be fair if I had a bad experience to say, well, I had one, but it was terrible. I had horrible bleeding, or I had a perforation, or what have you. One person's experience shouldn't be a blanket experience for everybody else. So going through the risks, the benefits, the percentage of things happening, your past history, your personal current goals and needs, and having everything evaluated as you as an individual is the best way of going about deciding if one of these devices might be right for you.